Good evening. I'm Dr. Josie Morse, and you're watching the episode 25 for Eternal Vitality podcast. We're going to talk about a very common and important topic today, low back pain. There is a significant chance you will develop low back pain at some point in your life. I know I have. The prevalence is really high. About 51 to 84% of people will deal with back pain at some point in their life. Whereas 23% of adults deal with it their entire life or chronically. That's a lot of people. There's a reason why low back pain is the most common cause of disability in America. Now, if you haven't been here before, I am a family and sports medicine physician with a medical practice in Miami, Florida. I specialize in regenerative medicine or non-surgical sports medicine with a particular focus on PRP, stem cells, and surgical, avoiding surgery, essentially, optimizing your health with injections and changing different lifestyle modifications. Now, we've talked about all different things in this podcast series so far. This is made for a combination of regular people as well as medical professionals. All of this stuff has been researched, and you can use this to reference if you need to. The different types of things that I see are sprinkled in here throughout the episodes. Last week, we talked about Achilles tears. We've talked about meniscal injuries. We talked about anti-aging. We've talked about one of my favorite drugs that is more of a supplement than a drug called methylene blue. There's so many different topics that I want to cover. My goal is to educate and provide more information than maybe you get from your physician, from the internet, or from other sources. I'm trying to continue to provide information in a way that is refreshing and understandable. If you have any questions or comments, I would love to hear them either on Spotify, Apple Podcasts, or on my YouTube channel. You can also reach out to me on Instagram or Twitter. I am also on LinkedIn if that's easier for you. Now, there was a Scandinavian study that showed 50% of 18-year-old females and 20-year-old males already had at least one episode of back pain by that time period. So low back pain in an 18 or 20-year-old is actually pretty common. Now, the incidence of age and in females, the back pain will go up. So males don't get it as often, and as you're younger, you traditionally don't get it as often as you get older. How expensive is this? How much does this cost, at least for the United States? The estimate is about $200 billion. That is an astronomical number. Very common cause of seeing your regular primary care doctor, which is the second most common cause secondary to respiratory infections, as well as in the ER, which is not exactly the right place, the ideal place to go, but sometimes the best place that they end up finding. Now, acute back pain that doesn't resolve in 6 weeks requires further imaging. 90% of back pain actually resolves within 1 year. So if you look at it and zoom out, you say, well, how long is this going to affect me? 90% of the time, it's going to be gone within a year. There's also I've noticed a correlation with hip injuries. Sometimes it's hip and it feels like back. Sometimes it's back and it feels like hip. Sometimes they're both. And you have a combination of I have back issues and they also hip issues. So if you only correct one, you will only fix 50% of the problem or 30% or whatever ratio you happen to be dealing with. Now, let's talk about the anatomy. I'm going to try to make this kind of overview as opposed to getting super complicated. This is a topic I could talk about for 5 hours, so I'm going to try to make it short, sweet, but impactful in about 30 minutes or so. Now, you have cervical, thoracic, lumbar, sacrum, and then coccyx. We're going to focus on the lumbar, sacrum, and coccyx today. We have vertebrae, which are the bones. We have the spinal cord, which is a huge, thick rope, essentially, encased with fluid running north to south in the back. Then we have the intravertebral discs, which are essentially in between each of the bones. And they are providing cushion, they're providing nutrients, and providing space for those nerves to come out. I usually like to describe the back as almost like a fork in the road. Half of the nerve goes left, half of the nerve goes right. Next level, half the nerve goes left, half the nerve goes right. Now, there's a lot of important ligaments in the spine, whether cervical, thoracic, or lumbar, that play a huge role. And more often than not, when we see it in our clinic, this is traditionally the problem. It's usually a ligament issue, meaning the back is not able to handle the stress of your everyday life, and it's allowing nerves to get compressed, or discs to be pushed on, or spinal cord to be pushed on. And as a result, you start feeling pain, having spasms, radiculopathy, different things that can present. There is muscles, there's tendons, there's also something called fascia, which is basically the tissue layer that runs in between muscles. And each of these can play a role. Now, there are three generalized types of back pain. You have acute, meaning relatively recent, 2-3 weeks. Subacute, I would say probably 6 weeks or so. And then you have chronic, which is usually 12 weeks, but it can be 6+ months. Now, what are some of the symptoms that you could be experiencing with back pain? Now, you could have sharp stabbing pain. You can have throbbing, aching pain. You can have numbness and tingling going down the back of the leg, the side of the leg, the top of the leg, the bottom of the foot, the top of the foot. You can have it down one leg. You can have it down both legs. Everyone is different, and this may change based on position, based on the amount of stress your body's dealing with, and it really may depend on what you're doing at that time. If that nerve or combination of issues is really angry, it may be really killing you. And right now, oh hey, it's doing pretty good this week. Now, if you ever have bowel or bladder changes, red flag, and we're going to talk about that in a sec. We could also have weakness and muscle spasms correlated with this. It's more so indirectly correlated, but there is a correlation. Now, what we call musculogenic is the most common cause of low back pain. It is associated with activity and characterized by stiffness and difficulty bending. Discogenic pain, meaning issues with the disc, is actually quite controversial and can be converted with what we call a discogram, which is basically like an x-ray where they put dye into the disc to confirm there's an injury to it, and it basically repeats the pain when you inject it. Now, discogenic pain is usually described as a loading of the low back without radicular pain. So meaning you feel it directly in the low back, but you're not feeling it down your leg. And this traditionally is worse with bending and with sitting. And if you lay down and lift one of your legs without bending your knee, called a straight leg raise, if that is negative, that is consistent with a discogenic back pain. If it's positive, then it's no longer that by itself. Now, mechanical pain is usually caused by facet degeneration. Now, each level of the spine has a bone, and on each side of the bone in the back, there's a little protrusion called a facet joint. Now, over time, those facet joints can rub against each other, and you can start to wear down the cartilage in those. You can start to get swelling, you can start to get inflammation, and eventually that's where we get arthritis. Now, this facet pain, facet issues, is traditionally what we call mechanical pain. You can also have either micro instability, so small movements within the ligaments, within the tendons, within the nerves, within the vertebrae, within the discs, or macro movements, meaning there's huge shifts. A lot of the times we can have the tailbone, which is something that usually does not get properly addressed. You can have someone lay flat down. You can evaluate their tailbone. It should be seated directly in between the hip bones, in between the SI joint. Now, but the tailbone actually has multiple ligaments holding it in place. Think of it kind of as like a shield. And what can happen is if it's sitting like this, sometimes it can rotate. And what it does, it can rotate. That can start impinging some of the nerves coming out, and that can cause pain. It can even cause what we call radicular pain, that it can be correlated directly to a nerve or actually from the fascia itself. So a lot of the times putting the tailbone back into its proper alignment can alleviate a lot of pain, because it's a space issue. Think the nerves cannot move out of the way of that bone. So they're basically the nerves being squished between two bones or muscles or a couple other things. Some people confuse this with piriformis syndrome. Piriformis syndrome is actually quite rare, but it feels similar. It's usually a combination of issues from the low back. Now, you can have issues with lifting objects or prolonged standing. That's usually a mechanical type pain. If you have a sacroiliac pain, it's usually directly feeling that SI joint, so kind of putting your finger right on that joint on one side or the other, and you feel that, yes, you can get arthritis in there, you can get inflammation in there. You can also have what we call peripheral or neurogenic back pain. This is usually radicular, meaning it feels like a lightning bolt going down your leg, usually on one side, but it can be both. The back, thoracic, and upper neck, for that matter, all have what we call a dermatomal distribution. So I want you to do me a favor, grab Google, type in lumbar dermatomal map, and see what pops up. When you look at that, you're going to see that we're not, the nerve structure of our body is very unique. It comes in strips, and they basically are left side of the body, right side of the body. They traditionally don't cross. So if someone has an injury to the L5, which is the most common spot, vertebrae or nerve or that at that level, you're traditionally going to have injuries in that dermatomal distribution. So that means that it's going to come out the back, it's going to go down the back of the leg, kind of run across the front of the shin and to the top of the foot. If the S1 or sacrum is involved, it's going to go down the back of the leg, kind of the back of the calf, and sometimes either the top of the foot or the bottom of the foot, depending on which one you're talking about. The L1, L2, L3, the top part of the lumbar pretty much stay in the low back, upper hip. L3 goes down to the quad a little bit. But you say, hey, I have an L3 injury, but I'm feeling something in my foot. It doesn't correlate, at least not always. So that is dermatomal distribution. Now, some people get referred pain in their buttocks, in their posterior thighs, and in their inguinal region, and that can correlate with a specific nerve that is irritated. Now, we can have something called neurogenic claudication. And this is something that occurs when you have pain in your buttocks. You can have pain in legs with prolonged standing. It almost feels like you're losing circulation to that part of your body. But it's not a circulatory issue traditionally. It is actually a nerve issue, and it basically means that the spinal cord is essentially getting squeezed. Now, the way we are designed is that if we look at the spinal column, if you were to take out all the abdominal organs and look straight in the front, you would see all the discs in the vertebrae. There is a huge, thick ligament called the ALL for short that runs north to south and holds those in place. That is a very thick ligament and very difficult to injure. There's another one on the back part of those bones that is right in front of the spinal column. And often that's the one that gets injured. The problem is when we injure the PLL, it traditionally has a tendency to compress the nerves coming out. And because the spinal cord is there, all the nerves are coming out each level, it becomes a space issue. There's also a big thick ligament on each side called a lamina. You may have heard of laminectomy. And that, again, is a structural support. But if it's compressing a nerve, think of you squeezing your finger and your finger being the nerve. A lot of the times that squeezing is going to correlate with numbness, tingling, pain, spasming, sharp stabbing pain. And when you can get a little bit relief, relax, that squeezing of the nerve or of the finger, you start to get some pain relief symptoms. Now, we can see this at multiple different levels if someone has a spinal stenosis, which we're going to talk about in a sec. We can also have something called myelopathy, which is not common, thankfully. And that means we usually have almost like clumsiness of the hands. We can have gait changes with the way we walk, and usually spinal cord issues. Now, if you ever have any of the following symptoms, this is go to the ER immediately. Number one, history of IV drug abuse when infection and acute significant low back pain. History of cancer or a tumor in the low back with significant low back pain. And a history of trauma, like a car accident or a fall with significant low back pain. Furthermore, if you add in Bowel or bladder changes, meaning you start urinating and you're not wanting to. That is a huge red flag. You start defecating, you're like, I can't control it. I don't know what's going on. Huge red flag, usually cauda equina syndrome, which is a medical emergency. Severe back pain that does not respond to any meds. Something bigger is likely going on. You need to get it checked out. So what are some of the risk factors of low back pain in general? Smoking is a risk factor. Prolonged sitting. Poor fitness level. Core muscles are king. They take a lot of stress off that low back. Obesity, weight gain, becoming a huge problem, not only in the United States, but throughout the whole world. You have all this extra weight truncally in your abdomen, and it's pulling all that extra weight towards the front, and now the back has to do extra work to keep you from falling over. Think of a pregnant woman that is carrying a baby, and you have all this extra weight. What's happening to those low back muscles, those spinal ligaments? They're trying to keep her upright rather than allow her to fall forward with that baby. Well, what happens when you're carrying 20, 30, 40, 50 pounds extra on your abdomen? Basically the same thing. But it's not just a short-term 2-3 month issue. It's usually a chronic issue. A lot of people, if they lose the weight, they will have significantly less issues, whether it's low back, whether it's hips, whether it's knees. It can help significantly. I use this quote in one of my knee videos, but I will use it here because it correlates. For every additional 1 pound of fat on the abdomen, or weight we'll call it, is an extra 4 pounds on the knee. There is a significant correlation with extra weight and having a pain. So think 25 pounds weight over the abdomen. Oh, that's not a big deal. Well, that's an extra 100 pounds on the knee. That's a lot of stress. Now, age does play a role. The older we get, the more wear and tear there is, the less stronger muscles, and usually back pain correlates. I have a fascinating study I'm going to share with you in a minute. There can be job-related issues. If you're picking up boxes and rotating and pushing and pulling and crouching in weird positions, you're probably going to have back pain. Chronic levels of stress. This is a huge one. I know it sounds funny, but there is a connection here. Also connected to poor sleep and depression. Now, hereditary or genetics. Some people, unfortunately, are born with a bad back, are born with scoliosis, a significant curvature that causes a lot of problems without you ever doing anything to deserve them. I have people in their 20s that have already had multiple back surgeries because of how severe the curvature of their spine was. Nothing was lining up. And there's a fascinating study or correlation with low back pain and job dissatisfaction. Interesting. Finally, an accident or a previous low back injury makes sense. You're going to predispose yourself to having a risk factor for another injury. Now, what are the most common causes of low back pain? In any order, we'll just say number one, spinal stenosis, which basically means that the bones are squishing the spinal cord, and the spinal cord is really getting squeezed. Usually this happens at L4 and L5. It can happen at a little higher levels in the lumbar, but not super common. You can have degenerative disc disease, or what we call discogenic disease, which basically means that the disc, which for lack of a better comparison is like a jelly donut, and when you squeeze a donut, you usually have two holes, one on each side. One of the sides squirts out, and that jelly donut just lost a lot of its weight or a lot of its thickness, and therefore the nerves that are coming out no longer have that same amount of height, and now they have less room to work with. Thankfully, in the low back, we have a lot of give. In the cervical spine, we do not. If you have a cervical herniated disc, it is a game changer, and you are utterly miserable. I mean, useless. I've had patients tell me that with cervical back pain or cervical neck pain, their pain was so significant that they literally asked if I could chop off their arm. Think about how much pain you have to be in to ask someone to do that. lumbar usually does not get there. The discs are a lot larger. The vertebrae are are larger. There's a lot more area for the nerve to move, for the disc to get a little bit comfortable. It just doesn't take a lot, a couple of millimeters, maybe a centimeter, and now they're feeling much better. Unfortunately, the neck doesn't have that same luxury. And then a herniated disc, as I mentioned earlier. There's a thick ligament that basically makes up the disc called the nucleus pulposus. And what can happen is you can herniate or push that out of where it belongs. And now you're starting to compress nerves. You're starting to compress the spinal column. And that can cause a significant amount of issues. You can also have what we call a spondylolisthesis or a spondy. And there's different levels of these. These usually are fractures of the actual vertebrae or where the facets come out, the little joints come out. And as a result, there's a lot of instability because the bone is no longer fully attached to the rest of the spine. You can have a sprain or a strain of the muscles. You can have a fractured vertebrae, as I mentioned a minute ago. You can also have scoliosis, which is basically an abnormal curvature, and there's different, obviously, levels of severity of scoliosis. And you can have what we call myofascial pain. One of the most common causes of instability, in my opinion, that we see quite often in our clinic is what I call lumbar instability. Meaning it's not one specific thing, it's a combination of a bunch of things. I usually liken it to a car with 8 lug nuts, and each of the lug nuts is a different ligament. And instead of one of the lug nuts being broken, maybe 3 or 4 are broken, and the other 3 or 4 are loose. So everything is shifting and shaking, and nothing is stable. That's often what happens in the low back, where one side is a little bit stronger, but the other side is weaker, and there's compensations, and then you rotate, and then the hips start rotating, and the nerves get squeezed, and then the disc gets squished. So there's so many different things because those ligaments are supposed to do the heavy lifting, not the bones, not the discs. But what happens? Think of the ligament almost like an elastic band that's super strong and tight. Everything was perfect when you were 15. But over the years, you start to stretch that ligament, stretch that elastic band. And over time, what happens? That energy that should be handled by that ligament no longer is handled. And it gets translated to that nerve, gets translated to that disc. And it no longer stays in that in the place it should be, and now it herniates that disc. Now it presses on that nerve. The goal should be to tighten up those ligaments. Unfortunately, it's easier said than done. That's traditionally what we use some of these different types of regenerative medicine injections I'll talk about in a little bit. Now, we also have inflammatory conditions. While these are not common, they can be very debilitating if you happen to have them. You've probably heard of ankylosing spondylitis or HLA-B27. These are usually autoimmune diseases that unfortunately do affect the back. You can have infections. One of the most common causes of low back pain is actually a chronic low-grade infection. A little difficult to prove, but it does happen. Pregnancy, as I mentioned earlier, does cause a lot of back issues. Unfortunately, it makes sense. Kidney stones can often be confused with low back pain, and even endometriosis, which are usually injuries to muscle issues within the ovary or within the endometrium of female organs, and it feels like low back pain. It's actually a little bit in front of the low back, but they get often confused. Now, if we were to break down the generalized classifications of low back pain, we would have several categories: traumatic, degenerative, oncologic cancer, infectious, inflammatory, metabolic, referred pain, postural, congenital, and psychiatric, or what we call malingering. Now, you're probably wondering, what is the easiest way to get imaging of the low back? Well, most of the time, a physical exam is very helpful, but it's not going to tell you how the back looks. X-rays are okay for guidelines for generalized overview, but it's not going to tell you how my disc looks, how my spinal cord looks. And in a CAT scan, we really only reserve for fractures or acute spinal cord injuries where you don't have the luxury or of time. But the gold standard is an MRI, ideally, in my opinion, without contrast, because the contrast is not benign, which should mean you should get a 3 Tesla MRI. That's the strength of the magnet. And that will show you fantastic results without having to use contrast. Now, there was a very famous study that I quote often demonstrating the study of positive MRI findings in asymptomatic patients. Now, these are patients that have no low back pain but had an MRI, and it showed a bunch of stuff. Now, they broke it down into 3 different groupings. Now, the 20 to 39-year-olds, 21% of them had a herniated disc. 56% of them had a disc bulge, and 34% of them already had disc degeneration. Remember, none of them are in pain. That is how common these injuries are. One of my favorite phrases is, I treat people, not pictures. The pictures help. The MRI helps. The ultrasound helps. But I need to see what correlates, what's actually going on in your body. I'm not just reading an image and say, okay, I need to fix that. Well, what if you fix that and their pain doesn't go away because that wasn't causing their pain? Measure twice, cut once. The second age group was 40 to 59. 22% had herniated discs, only 1% more than the previous group. 50% had disc bulge. The disc bulge actually went down, the percentage. But 59% of them had degeneration. It makes sense. It's a chronic disease. And finally, 60 to 79. We expect most people in their 60s, 70s, and pretty much 80s to have some type of back issues. And they do. But only 36% of them, about a third, have herniated discs. 79% have disc bulge, so almost all of them, and 93% of them had degeneration. If you find someone in their 60s, 70s, or 80s that doesn't have a wearing of a disc, they are an anomaly. That's rare. I'm expecting you to have a disc degeneration. Now we're going to finish up strong with the treatments. What different things can we do to these? This is such a common issue. You should not be popping Advil or Aleve or Mobic or any of those like candy. That is not good for you. My personal choice is curcumin, which is a derivative of turmeric, which is a natural plant often found in India. You can use Tylenol, although it's not always the most safest option. It's a little bit safer than any of your anti-inflammatories. And then, unfortunately, some people eventually have to turn to narcotics, which is never the correct answer, but sometimes a necessary evil for a short period of time. Now, believe it or not, exercise works really well for back. Also, traction therapy, basically think of stretching that spinal cord out, all those discs out, give them a little bit of space for that nerve, for that disc to breathe. And it may only last a little bit, but it can help for some people. It depends on the type of injury you're dealing with. You can have spinal manipulation, whether it's a chiropractor, whether it is an osteopathic manipulation, which is an osteopathic doctor. And you can do acupuncture. Acupuncture can help with this. Now, some people opt for muscle relaxers, like your Flexerils or anything like that. And some people even go for gabapentin, which is a neurological medication that can help with some numbness and tingling and sharp stabbing pain down the leg. Now remember, these are Band-Aids. These are not treating the problem. They're only helping your symptoms. Get to the root of the problem and you won't have to do any of this stuff. That's what we focus on in my clinic. Now, some people opt for heating pads. They're much better than ice. I think that's a good idea. And also, stretching is important. A lot of the times, the hamstrings are super tight. It's going to cause an issue with your low back. And we can even have issues that can be temporarily resolved with a lidocaine patch. They sell them over the counter up to 4% strength. You put them directly over the injured spot, and it can give you a little bit of alleviation. I am not a big fan of oral steroids. They are very risky. They cause a lot of problems. They spike blood sugars and blood pressures, and they really damage ligaments and tendons. There's a correlation with Achilles tears. So they're very risky. Do they work temporarily? Yes, but they are not fixing the problem. They are just simply masking the situation. Now, people often ask about back braces, and wearing a back brace 24/7 is not a good idea. Why? Because the work of the muscles is being released, and the back brace is working too hard, and now those muscles are taking a break, and you need them to work. If they're not working, then they're not going to maintain their strength, and then you become weaker and even can have what we call fatty infiltration of the low back muscles. Where you look at the low back muscles in MRI and you actually see fat infiltrating where muscles should be. That means they're not using their back muscles enough. And the back's like, okay, you don't need it. I'm just going to fill it in with fat. Very scary and very hard to reverse. Now, if you're, lifting something heavy, you're in the middle of a deadlift, you're moving some boxes or something. Okay, different story. But day to day, you should not have to depend on a back brace. If you do, you need to get to the root of the problem. That is not going to solve it. Now, there are different types of injections. You've probably heard of an epidural. Now, that is relatively straightforward. Usually either a pain management doctor or an orthopedic spine surgeon or something along those lines is going to inject usually a cortisone type substance in and around a nerve, or we call it caudal, which basically means at the bottom of the spinal column, and it just floats up. These are great for decreasing pain and inflammation, but again, they're not fixing the problem. They're just helping with symptoms. You can do that with stem cells. You can do that with what we call PRP as well. You can also do it with something called dextrose, which is a derivative of sugar that actually helps to calm down the nerve. What we do at our clinic is a little bit unique. We focus on injecting each ligament and tendon, including each of the facet joints, and in and around the different ligaments of the spinal column, around the tailbone, sometimes even around the hips, in order to stabilize those ligaments and tendons and to help prevent that progression, or really address the instability, which translates to pain, stiffness, and immobility. Now, you can do this with as little as prolotherapy, which is that dextrose. Next round above that would be PRP, taking blood out of your arm and spinning it down and putting that into each of those areas. Or if it's severe enough, you might have to opt for a orthobiologic or a stem cell line. And there are several of which. These are actually going to address the root cause. You can inject those into the disc. That usually is done under anesthesia, but not always. You can inject ozone into the disc. You can inject different substances like methylene blue or a peptide like BPC-157. You can also inject stem cells. There's many different options. There's even something called ViaDisc, which we've been using for a couple of years now. This is an FDA-approved product that actually helps. It is a dehydrated cadaver disc that is reconstituted with saline. You aspirate it out and you inject it into the disc, basically helping to reorganize and reformat the disc itself, which then can help with pain. It can help with some stability and size of that disc as well. Now, let's talk about different types of surgeries. Now, no one ever wants back surgery, but sometimes it's a necessary evil. The best back surgeons don't want to do surgery. It is the last option. If someone is gung-ho about doing spine surgery for you, unless you have any of those red flag symptoms, you should walk away quickly. That is not the first or second or third option. When you've exhausted all the other options, then that's what you should look into. Now, you have what we call microdiscectomy, which basically means they remove a little piece of the disc that is causing problems, herniating on the spine, so on and so forth. They have something called a laminectomy, which basically means they're removing a piece of the lamina or ligament that is compressing a nerve or causing an issue. The problem is you're removing an important part of the stability structure and still expecting it to work. It will help with the pain, but you just made your spine weaker. You can do a fusion, which basically means they're putting metal rods or screws through one or more than one level to prevent movement. It stabilizes and keeps those nerves having plenty of room, and it prevents those discs from collapsing. The problem is the spine is meant to move. It moves as we move. So if you think about it, if you're supposed to move L4 and L5 and now you just fused them, now you're going to translate that energy above and below, and eventually you will herniate the discs above and below uh, because that disc is no longer able to move because it is fused. Now, they do have lumbar disc replacement, and they have better 2-year outcomes than fusions. And you can also do, extensive rods and screws and a bunch of other stuff. That's for a separate topic for a separate day. Now, I'm going to finish up with an unfortunate issue that needs to be discussed that may not be discussed if this is something that happens for you to come across as it pertains to surgery. There is something called failed back surgery syndrome, or FBSS. It is a real thing. Look it up. The most common cause of this is lateral stenosis of the foramina, meaning where the nerve is coming out the side, it usually starts to squeeze, and that's why they continue to have pain. Now, this happens in 10 to 40% of back procedures. That means 50 to 60% of back procedures are successful. The other 10 to 40% of people still have back pain. That's not a good ratio. Now, if it's specifically for lumbar fusion, this is the worst of them. 30 to 46% of those people still have pain after their surgery. So think about that before you have your fusion. Whereas if you have a microdiscectomy, only 19 to 25%, basically 1 in 4 to 1 in 5, still have pain. So you have basically an 80% chance of being in less or no pain. I hope you found that helpful. This is a very common topic. This is going to only worsen with the severity of obesity, with the aging populations, with people that are not eating the best, which I believe there's a correlation with food quality, with all of the different seed oils and pesticides and all the different inflammatory foods, the glutens. Indirectly, they're going to have issues with their back along with everything else, causing increased obesity rates, which indirectly causes low back issues. And most people are not exercising to the extent that they should, that they need to get out and move. And unfortunately, many people are not. And as a result, this is one of the symptoms that they deal with. Low back pain for most is inevitable. You can get ahead of it. And I mentioned some of the different things that you can take to help. If you found this helpful, do me a favor, smash a thumbs up, subscribe, maybe leave me a review, and share this with one of your loved ones or your friends that you think would find it helpful. Thank you very much. We'll see you next week. Take care.